Number 6, a cancer diagnosis and then genetic testing. More and more doctors are looking at a patient's genes before starting chemo or radiation to ensure that the therapy is tailored to their tumor. Now, with more on this practice, we're joined by our medical correspondent, Dr. Sujatha Reddy. And Dr. Reddy, as always, a pleasure. Thanks for joining us.
Thank you.
You know, this is remarkable stuff. How does knowing the tumor's DNA help doctors?
Well, as you said in the lead, by knowing the tumor DNA, you can tailor-made or personalize the chemotherapy for that specific tumor. There were 2 reports that came out in the Journal of the American Medical Association this week showing that by identifying specific DNA sequences of a tumor, doctors were able to specifically pick appropriate specific therapy for those tumors and really help the patients and their families, as some of these tumors and the genetics can be passed on.
Dr. Reddy, maybe you can help us understand what's the traditional or the current way that doctors currently treat cancers. Is it one size fits all?
It kind of is. We use chemotherapy to attack cells that are rapidly dividing or rapidly being produced, but we use specific chemos for specific types of tumors. Melanoma has a specific kind of treatment. Ovarian cancers have specific chemotherapies, but there's some people who respond to these chemotherapies and some that don't. So by identifying specific genes, you can target your treatment to those specific types of tumors and thereby also probably save the patient a lot of side effects.
You know, it seems like this is a better way to treat the individual, but there is some controversy over the cost, right?
Absolutely. When the Human Genome Project came out in 2003, it was a really earth-shattering medicine. And in 2008, they started sequencing tumors, and now we've identified specific cancer markers like the BRCA1 and 2 gene. The cost has come down a lot, and these studies that were published this week, the genome sequencing costs between $10,000 and $40,000, and that's a lot less than it used to. It used to be, 100 times that, but it's still very expensive. But I think it's the direction that medicine is going to be heading, and this should come down in cost as more and more companies are out there actually diving into this area of research. And as it gets cheaper, I think we'll do this more often. But right now, it really still is experimental to some degree and not standard of care. But hopefully in the next several years, it will become so.
All right, Dr. Reddy, always a pleasure. Thanks.
You're welcome, Keith.